Hello, welcome to the Voyage Clinics podcast. I'm your host, Dr. John Sanders, family physician. And today we are going to talk about a super fun topic. We're going to talk about healthcare coverage, innovative things, and what do families do? There's a whole bunch of changes going on right now with the Affordable Care Act and the Big Beautiful Bill and all the legislative changes that are happening. And the price of coverage of insurance just continues to go up. And it's just a hard deal. And so are there options for individuals, for families, and for small businesses, or even middle-sized or large businesses? Some innovative, cool things. And I've brought Dennis Walker on today. Thank you for joining us.
It's good to be here, John.
Dennis, tell us a little bit about yourself. Where are you from?
I'm from Tampa, Florida.
Let's go, Florida.
Yeah.
Med school residency in Florida.
Go Buccaneers.
Yeah.
Go Rays.
That's right.
Right?
That's right.
I miss home. I miss the beach, but Utah's been really good to us.
Good.
So I'm glad I'm here.
Nice. How long you been here?
About 16 years now.
Wow.
So we've tried to go home twice. Disasters both times. Complete disasters. It was so bad the last time we went. And I'll tell you what kept us afloat was I had a couple of groups that I was getting paid on every month, and everything else went sideways.
Oh, geez. Oh, man.
I miss it, though. One day we'll go back. I'm looking to buy a beach condo down there, probably north of Sarasota.
Okay, yeah. That's some pretty beach up in that neck of the woods.
It is, yeah. Yeah. One of these days I'll go home.
Yeah. Well, tell us about, so what's your education? What's your credentials? Where are we at just as far as that background?
Sure.
And then tell us what kind of moved you in that direction.
So I have a degree in business management and have studied psychology, have a minor in accounting.
Cool.
I hate numbers.
Yeah.
But I know them and I'm good at them.
Okay.
But I like people. And I have also a professional sales certificate.
Okay.
And that's probably been the most valuable part of my education.
Yeah.
How to sell, how to get things done, keep things moving, get the ball rolling. It's been phenomenal to work in this space. I was recruited originally in 2011 into the life insurance space as an intern. I got licensed that following September, sold my first group health plan in 2012. After selling several individual policies. The ACA had been passed, but it hadn't kicked in yet.
I see.
And in 2013, my commissions were destroyed. So thanks, Obama. It is what it is. And I've learned how to get around that. And so it's about 1/3 of what we used to get paid.
Really interesting. Really? I didn't know that.
So commissions in the old days were a lot more generous. And the prices for policies were a lot lower.
Right.
There was a lot of things that changed around pre-existing conditions that caused that to be a thing.
So if I hear you correctly, because the ACA, the Affordable Care Act, I think they got rid of pre-existing conditions, right? They said anybody that's offering insurance in the United States has to cover pre-existing conditions. So now they could no longer refuse to cover certain people.
Yep.
And
even the Trump administration has recognized that that's been probably the most popular with the people part of the ACA. And they have said, we're not going to remove that. And so that mandate, as far as I can see, is probably here to stay with this environment. And so, I came from a household where we were poor. We didn't have a lot. And so we relied on insurance to pay for medical care. And I remember my mom getting 3 different treatments and medications denied because of a pre-existing condition before all that passed. So, I see the benefit of it while understanding the actuarial difficulties that go along with it.
Totally. Yeah, totally. What drew you towards the health insurance brokerage thing?
So I wrote my first plan in 2012, like I just mentioned, and I remember having the conversation with the business owners. I liked working with business owners because they had a bigger view on life. They weren't just showing up for a paycheck. They were there to build something. Yeah. And I liked that I was able to use my expertise to help them with that. I liked the residual money that came from it, right? We get paid a commission every month on a group that we are the assigned broker to. And I liked knowing that I could help save lives without having to go through a residency in medical school, as you wouldn't fully understand. Yeah. Sure. So it's if it's something I get wrong, someone can die. So I have to be a professional. I have to know my space really well. I have to design the plans with intention. I have to be careful about what hospital they're going to and what kind of results they get and which doctor they see. And I'm sure there's doctors that you wouldn't want your children seeing out there. And we have the data, if you're a good broker, to determine who those good doctors are. And being able to give my clients resources is what's brought and kept me there.
That's cool. That's really cool. So it sounds like you have a passion for taking good care of people and help them figure out the coverage part of their equation. Since before ACA, and this is kind of unique because you have some pre-ACA experience, plans were quite a bit cheaper, and part of it you mentioned was just because they were like mitigating risk by mitigating those pre-existing conditions.
Correct.
Folks that are gonna be higher. How much have you seen plans increase since that change? Like because everybody that I know, we take care about, I don't know, 15 or 16 local companies.
Yeah.
And every year, if they have a group plan, they're going up by a pretty large double-digit percentages. And it's just not sustainable for these average small companies. And I can't afford to provide insurance to my employees. And I'm a doctor. And I mean, we keep our price points at like super reasonable for what brokers probably make more than I make per month, per family type thing. But I really enjoy it, and I like the affordable, transparent healthcare we can provide. So I don't know, you've seen these escalations. How do you see them stopping? Do you see them plateauing? Do you see any changes coming down the pike?
Every time I think I've got a hold on it, something else changes. Legislative, regulatory, or just market, right? The government is trying to control this as best as they know how. And this really is still very much a mixed market situation. We're not totally socialized. We're not totally free market. There's a heavy subsidized mix of what's going on in between. But to answer your question, since the first plan I wrote up until today, I've seen premiums on an average healthy group double, on an unhealthy group as much as 400% increase. So very significant increases over the last 12, 15 years. It's been, like you said, unsustainable. And sometimes it's because of practices going on inside the insurance companies that they don't necessarily make known to the public, where they're padding in profits, overreacting. And a lot of these increases aren't just unsustainable, but they're also unsubstantiated. So there's no real actuarial science besides an emotional overreaction, which makes me violently uncomfortable when I come to sell these to my clients. And so I've sought to put as many control methods in place as possible. And, there's got to be a change in our industry. Yeah.
Something's got to
There has to be. Yeah. And it starts with the brokers. It absolutely starts with the brokers. The brain dead brokering has got to end. And so while I believe I've aligned up with the best company and the best resources, other brokers can still take a lot of what we're going to talk about here today, what I'm ready to talk about with you, and they can apply it into their practices. I'm always looking 5 years out. That's the first thing that I'm looking at. And then I'm looking to put control methods, predictability, and to not just negotiate with the carrier and pit them against each other, but to really come at them with an actuarial math, numbers-based argument and say, hey, here, and here is where you're charging too much. Here's where you've not kept your contract language in check, and maybe where you've even broken the contract in a bad faith effort. And we're going to hold you accountable, or we're going to take the business and put it somewhere else. That gets carriers to play ball.
That's super interesting. I had never thought of a broker advocating for the company like that. Like what did you call it? Brain dead brokering. You can maybe they're just coasting. They're not really putting brain cells to the equation or advocating for their clients like they should. Yep. I never thought of that. At Voyage Clinics, we advocate for our clients on a daily basis, finding them like the most cost-effective ways to get to certain medicines, certain imaging. Today, we helped a family get an MRI for about $299. And yesterday we saved a gal because she was going to fill her medicine at this one pharmacy. Same medicine, generic. At another pharmacy, it was only $26. It was like $115 over here. So just little things like that we do to just like look at and help mitigate those. It's so cool to hear that you're doing that in the brokerage space where you're holding these payers accountable in a very numbers, even though you hate them, but you're crunching the math, you're doing the numbers, and you're saying, hey, maybe we're paying too much in these ways, and maybe y'all aren't really keeping your end of the bargain there. That's cool. That's really cool.
And they usually aren't keeping their end of the bargain, to be clear, especially around pharma. It can be very dangerous to the plan and the way that it functions long term. But they continue to do it because that's where they're padding most of their profits, because pharma is the one area where they're not held to ACA profit caps. So
I want to circle back to that, put a pin in that ACA profit caps, because that's a perverse incentive thing that was not intended to become that, but it did actually become that. Yeah. We'll circle back to that, but I want to hear more what you're saying about the medicines. Yeah,
about medicine in general. There's all types of.
Describe that profit gap.
Yeah.
And that way the listener can understand, like, they're not held accountable to those ACA profit caps.
Yeah, for sure. Pharma isn't technically insurance. For whatever reason, they've been able to work out some loophole in whatever they're doing, regulatory or otherwise, to where it's not technically considered insurance. And so that's where they're padding most of their margins. It's still all ending up in the same coffer ultimately. Wild stuff that they can get away with that. But if you know what a rebate is, it's when the medicine is purchased and then a certain amount of money goes back to the plan, or maybe it's just discounted altogether. The pharmacy says we're going to give it to the patient at this price. And then the insurance company says, okay, we want to spread this much, so that way we actually pay here. Each carrier negotiates its own price on what they're going to pay the pharmacy and the manufacturer. There's no consistency in what's going on here. So they'll come in, and then instead of charging the plan that discounted, they'll actually charge the plan the 100% or maybe even above that. And so now we're driving up what's being paid out in claims completely artificially, and it's all going into the coffer of the insurance company.
Wow. And there's no check or balance on that, and there's no transparency there.
Right.
So interesting. Wow.
And there is transparency, to be clear.
Yeah.
If you have the right plan and the right broker who knows what to look for. So it's the market that has to hold the pharma piece accountable.
Yeah.
We have to.
Yeah.
And if we don't, as brokers, really understand how we need to behave, that the insurance companies are not our friends, even though they pay us. And they're not our clients' friends, and they're not the doctor's friends. They're not even the pharmacy manufacturer's friends. They're nobody's friends except their own and the government's. And if you understand that as a broker, your whole outlook on how you need to negotiate for your client changes.
Wow. That's a powerful comment, especially coming from you. And I want to talk about the ACA, that stipulation. The ACA doesn't allow it was the one that you just mentioned, where because medicine is outside of that pharma, they can move the bread around a little bit differently in that space, but
a lot differently
in their space. Tell us about the regulations there that the ACA implemented that actually became a perverse incentive for them as well.
Yeah. So in 2010, when the ACA was passed, one of the Democrats' moves was to cap profits on the insurance companies. And the insurance companies in turn said, we're going to go ahead and go along with this because we know that we're going to be getting government subsidies to pay for these plans. So, the BUCAs, Blue Cross Blue Shield, United, Cigna, Aetna, they kind of led this charge. And there were some other insurance companies around at the time that are no longer here that were part of that as well. But one by one, each of these insurance companies got in bed with the government over the course of 2 years, while Obama and his friends in the Democratic Party with their supermajority began to put together and then push this legislation. And shortly before the 2010 midterms, when they lost that superpower, that supermajority, they passed the ACA. And so they capped the profits at 20%.
20% of what?
20% of
expenditures,
premiums, et cetera.
Yeah.
Like they named it in multiple places throughout the bill.
Yeah.
And it still just chafes my hide to this day to hear Nancy Pelosi go, we have to pass it to find out what's in it. I think that's maybe one of the most harmful thing that's been done to our nation is passing that bill. But the fact is, it is law and it's here to stay, and every broker needs to learn it.
I want to speak to that as a perverse incentive. So it is, and Marty McCary, he's the head of the FDA right now, but he was like he is a brilliant mind. Johns Hopkins, cardiothoracic surgeon, head of research at Johns Hopkins, like excellent. Very bright. He was a keynote speaker at one of my direct primary care conferences 2 years ago. And he was fabulous. And he laid out so clearly and so beautifully the parts of our healthcare system that are broken. He mentioned the pharmacy piece.
Yep.
He also mentioned this part right here, which is insurance companies have a cap on their profit margins, no more than 20% of expenditures. Yep. So they're perversely incentivized to spend money.
Yes.
So they want their expenditures to increase because then the next year they can increase what they charge.
Some of those areas where they are perversely incentivized is commissions. Okay. So even though commissions are capped, they still have a fair number that they can pay us. And really, they can pay up to $50 per employee per month, PEPM, without anybody batting an eye. And it used to be closer to 100, 120, but the margins were different back then, and it could work just fine. But and then they comp us indirectly. So if I sell so much for a certain carrier, they might award me with a trip or a gift card.
They still do that, or that was?
They still do that.
Oh, interesting.
Yeah. I try not to write too much of any one carrier personally, and I know some agents who prefer 1 to 5 carriers, and they get their trips, and I don't hold anything against them for that. It's somewhat enjoyable, and it's not their fault.
This is eye-opening, I think, to a lot of people. I think to understand the workings of that space. The perverse incentive I'm talking about also is just it does not incentivize hospitals to find the best deals.
No, it doesn't.
Or insurance companies to find the best deals, and it doesn't incentivize hospitals to come down to something reasonable when they charge things for their like their surgeries and things like that.
If anything, it's incentivized them to drive the prices up.
Correct.
Right.
Yes.
Because they need more cash to operate.
Yep.
Their operating expenses have gone up. And so to match that, the prices have to go up. And Medicare pricing is kind of that American standard of what does a Medicare patient's plan pay? And we're seeing things 2, 5, sometimes 10 times Medicare right now with costs inside hospitals. It's unsettling.
So I just think that's super interesting. I'm part of a movement of direct primary care docs that are bringing affordability and transparency to almost all spaces of healthcare. And one of them is this space of cost. And so we'll actually go negotiate for our clients to find the best rates for x-rays locally.
Great.
The best rates for surgeries locally, the best rates for medicines locally and nationally. And so we kind of carve out all of the other fluff, and it's just direct. And so I think part of, as we move forward and something's got to give, like I think this movement of more than 2,000 of us now nationally working to bring affordable, transparent healthcare to the masses, I think it's got to be a part of the equation.
It absolutely does.
But coverage is still super important. So we're like, our core value is care that's affordable, transparent, and available when you need it.
Yes.
And so that's kind of our mission. And we're, for the most part, I probably will operate exactly like a nonprofit. I deal a fair amount of free care and a fair amount of at cost care, and so our margins are really razor blades because we're playing in the direct market, and so
sure.
But it's interesting. We can get medicines. You see these direct primary care doctors. More than 29 states now allow for these direct primary care docs to prescribe out of their offices, and when that is allowed, we cut out all that stuff.
Yes, you do.
And then what happens is, I can get your 3 months of lisinopril. Oh, why don't we bump that to 6 months of lisinopril? And I can get that for about $1.80.
Right.
Like $1.80 for 6 months of a medicine? Like, what? And it's insane. And so we can now bring transparency and affordability to the pharmacy space for our clients. Yes. I'm not sure the ripples with the insurance companies and all that, but I don't really care about those ripples. I care about people, and I want people to have affordable meds and affordable care.
So do I. Yeah.
It's like, and it's neat because when you and I met a few weeks ago, I knew there was something different there. And so, and I think it's cool. And your candor today is so open and transparent. And I think it's just unique and it's refreshing, and I appreciate that. I think it's because you're from Florida.
I'm definitely a mix of a Southerner and an East Coaster, right? And in Tampa, the fun thing is that there's a lot of New Yorkers, a lot of New Jerseyans there, and they just love the direct talk. They've taught me how to be a shark in business, and I appreciate a lot of those friendships, but with the Southern gentility that comes with it.
That's right.
And so I can present it in a way that feels soft and kind, but on occasion I'm going to say, no, this is wrong. This might even be bad faith, and occasionally what's going on is evil because it's not taking care of people. And when we start making money the objective over taking care of people, that's a problem. And I say that as a free market capitalist, right? When we stop caring about people, capitalism breaks. And I think that's where we are today. And it's become such a controlled mixed market where 4 very large companies now really control what's going on in bed with Uncle Sam, which, again, to use the term, makes me violently uncomfortable. So it changes here on the broker level. It has to change on the broker level. And so I'm hoping that other brokers listen to this today. And I know I'm going to piss some of them off. Right. But to the ones who hear me, and it's probably going to be about 10%, the change starts with us. So I want your audience to understand like what types of brokers there are out there. How to select them, and then how they can help you design plans, design strategies, what might be the best plan for your group. There's the first type of agent is a captive agent. You as a direct consumer or a business owner need to avoid that agent and let us brokers interact with them. Okay, so this guy would represent Cigna directly or Select Health here in Utah directly. Don't go direct to these companies and buy them because they're going to mark things up as much as they can. They know that you're not going to know the game, and you're going to get overcharged every time. Every time. Avoid
what is that called again?
Captive agents. They can sell for one company.
Got it.
Okay. Let us brokers interact with them. Those guys have a job. Carrier reps are very important to us, and we'll build a great relationship with them. But I can pick up the phone and say, hey, Jason, this isn't going to cut it.
You hold them accountable.
Right.
Right. Unlike me, I go to them. I don't know. I'm just like.
And maybe you as a doctor might be able to see a little more in there.
No, I'm blind. We're all blind.
Right. So then your next one is your spreadsheeter. This is the bottom of the barrel brain dead broker. They look at everything every year. They pit all the carriers against each other. They spreadsheet it all. Whoever comes out with the best price, that's who gets the business that year. What's bad about that is it actually affects your risk score if you are hopping carriers from year to year. And so frequently I'll meet a prospect or a client that says, our broker has or does shop us every year. He shouldn't. It can hurt your credibility with the carriers to switch every year, every 2 years. They see that as being screwed, especially if you have a bunch of high claims.
The residency hospital that I did in Florida, Jacksonville, they change carriers every single year. So they were just that kind of a broker. What did you call that again?
Spreadsheeter.
A spreadsheeter.
Yeah, so he puts it all in an Excel spreadsheet and sorts it by lowest price and says, go with them.
Got it. And that's not always a great strategy. It seems like a great strategy.
Right.
But it's not, because it increases your risk score, which then probably increases your premium with the
overall. Yes. Yeah. Yes, it does. Year over year, you will watch your premium trend upward if you do that.
Okay.
It's not great. So the other thing is you're buying on price there. And you need to learn to buy on value and on what your people are going to get. And that may mean selecting the second or the third from the bottom based on the network and the carrier and the payouts and the ease of access and the concierge service and the steerage, right? And if you don't know what these things are, then it's time for you to sit down with a broker who knows what he's talking about. The third one is, we call them the lock and leave. So they put you on a carrier, they lock you in, and then they never shop you again. That's also bad, because once you're on a carrier too long and they're collecting your premiums and they're trending you up anywhere from 8 to 15% a year. That's what we're seeing right now for healthy groups. Over time, again, there's going to be unsustainable raises. What may also happen is in the beginning, they may buy your business by giving you an artificially low premium. And then a year or two later, they increase you 30 or 40%. We're seeing a ton of that right now with Cigna.
8 to 15% increase on a healthy group.
On a healthy group. And I have seen increases across several carriers, 40, 65, 67, and one group was 100% increase this year. Their premiums literally doubled.
That's insane.
How do they expect to sustain this? They can't.
Insane.
So, there's that. And then your fourth broker, this is a smarter guy. He understands underwriting. He understands what goes into there. Maybe his team has an in-house underwriter. This is a good broker. May not be the very best, but there's a lot of good big brokerages out there like this and good small brokerages out there or local who understand what goes into the underwriting there. They can go and they can present a math-based argument and say, hey, this is where it should be. But they don't bring anything truly innovative to the conversation. And that's your fifth broker. That's really who you need to look for. And it's worth the time to both shop for them as well as follow the direction they're going to give you. They shouldn't change everything all at once. It should be a process that rolls out because you have to change human behavior and how they're utilizing the plan on the employee level and train them. So you got to unfreeze them, get them to change, and then refreeze them into this new way of doing things. But as you do that, over time, you won't just stay flat. You'll trend downward if your group is healthy.
What's that final broker called?
I call them the innovator.
Innovator broker.
Yeah.
Okay, I'm shopping for a plan. How do I know who I'm sitting across the aisle from? Like, how do I know if I'm dealing with this one, or that one?
Yeah.
Like, how do I? What are there some questions my clients can ask? Even as a business owner, what are the questions? Let's just focus on that space because I feel like that's totally your specialty.
Yeah.
I'm a business. I got this many employees, and I'm sitting across from a broker. And what are the questions I should be asking to know what kind of broker I'm talking to?
How many companies do you or can you represent? The more, the better. And what types of companies do you represent?
You mean insurance companies?
Mm-hmm.
Yeah.
Yeah. Who can you sell, basically?
Yeah.
And if they're going to tell you one company or just those 4 bukas, get out.
Get out.
Right?
Yeah.
That's not
captive. They're too captive.
Right.
Yeah.
Right. Even just those 4 bukas.
Okay.
That's not enough.
Okay.
Right? Because those are the big boys. You need local carriers. You need third-party administrators who offer some alternatives.
Yep.
Depending on the size of your group, there may be some better plans with a smaller local carrier or regional carrier. So here in Utah, that's Select Health. They play regionally very well. EMI is another regional one.
Okay.
But those are some of the bigger ones. I work with several smaller groups as well.
Okay.
And a lot of these smaller groups are nimble and they can move quickly and they can incentivize and they have faster resources. And they're not slowed down like a lot of these other behemoths are. So ask them how often they change their clients.
Yeah.
Figure out, how often are you shopping them? A group, if they're trending upward, should be taken to market every 2 to 5 years.
2 to 5.
Yeah.
Okay.
Yeah.
Okay.
Much longer than that, you start paying unnecessary profits and premiums.
Got it.
And then ask them if they understand underwriting and if they have an in-house underwriter. Ask them where they feel like the profits are padded into a plan. Mm-hmm. They can't answer that question. They don't know what they're talking about.
Got it.
Okay. And then ask them how they innovate. And so at the core of every plan, in my opinion, should be direct primary care. If there is a truly innovative broker.
I'm going to high five you for that one.
Right?
High five, bro. No, it's so true because a direct primary care at the center of any plan mitigates that plan. Right now, most of my clients have insurance. Mm-hmm. They're not in any kind of business group plan or anything, but we are mitigating the heck out of the whether it's Select Health or one of the Buka plans. Like they don't go to the ERs rarely. They rarely go to the hospital. They rarely go to the urgent cares. We are available, accessible, affable, and affordable, and it's just lovely. And what's interesting is DPC also saves the person money.
Yes.
Even if they have insurance, which is like a mind game for them.
On
like, what do you mean we're saving money? Like we're saving you money and we're saving your insurance company money.
Yep.
And it's
instead of a $45 copay, let's say you got an issue where you need to be at the doctor every week.
Yeah.
Or maybe it's a $90 or $100 copay if you've got a specialist. Now you've got one flat price. You can predict that and you can work that into your budget.
Yeah.
Right. And not just
There's
you.
no
So maybe your employer doesn't pay for it.
Yeah,
Maybe
no
you do.
co-pays. Yeah.
Right.
They just come in when they need.
And you get what you need at an unlimited basis. This creates predictability on the employee level and in their household budgets and in your plan.
Yeah.
And especially if you have a self-funded plan where the company is funding most of the claims going through the plan, partially self-funded, however you want to refer to that. That really creates a cost stabilizer within the plan, and you can incentivize your people to use that direct primary care and maybe a direct specialist care as we expand a little bit further on that.
Yeah.
If we can, there are other models. Dental care even has subscriptions like this. There's dentists understand this a lot better than your typical doctor does. They're businessmen at heart, most of them, who enjoy working with people, and so they learned dental because it pays well. And this model has been working very well in dental for a long time. So, and the last thing you need to ask your broker, and no matter which of these 5 he falls into, how often are you meeting with your clients? Bare minimum, they should be meeting with you once a quarter. Bare minimum. Because things change quarter to quarter, especially in a growing company or a declining company. If things are changing quickly, they've got to be in there. And some of my clients meet with me once a month. Others I talk to every week because things are changing and we're trying to figure out what part needs to move, and I need to be there and engaged. And I have a client in Washington State. I just got back from visiting with them last month, and I'm asking them to make some fairly uncomfortable changes that I know I wouldn't have been able to make effective if I wasn't there in the room with them.
Yeah.
So I'm going to get on a plane. I'm going to stay in a hotel away from my family so I can make sure that these people can be at home at night with their families.
That's pretty cool. Above and beyond. Next level broker action.
That's what you want out of a broker, is somebody who's going to come out there and, okay, it costs us $1,000.
Yeah. Talk it up.
Right.
Yeah. That's so cool.
Yeah.
I want to talk about some of this self-funded space. I feel like you have unique experience and expertise in this area. How many employees should I be thinking about? Oh, maybe we should do a self-funded kind of situation. Or is it not the number of employees, but maybe how sick or the ages of the employees? Like, how should we look at this as business owners?
I don't think there's any one right answer for any particular company. I think it's a case-by-case basis. Some I've recommended as early as 40 employees. Okay. This company was financially stable. They had great coffers, to be frank, sitting on several $1 million. They had a couple of uninsurable risks outside of medical. And so we ended up creating an insurance company they owned in a concept called 831B, and I could talk for 3 hours about that. I'll nerd out there because it's a great tax play in addition to its purpose, which is to insure an uninsurable risk. And we were able to move the medical into that 831B along with their work comp and their auto and some other risks that they had. 40 employees, but I want to say they were sitting on like $100 million. It was just stupid money. This is a great play for them.
Right.
But I've got another company, they're 150, and I'm actually going to keep them fully insured for the next couple of years until we understand where claims are. They've never really dug into claims data. And so we've moved them. They weren't even comfortable moving to the in-between stage, which is called level funding. So we moved them to a different carrier that will give them better claims data, similar network as far as hospitals and doctors were concerned. So, we try not to disrupt too heavily when we're making some changes. So it really just does depend. But I would say average, you can start looking at about 50 employees to move to a plan where you are at least partially self-funding the claims. By the time you're 500, you absolutely should be fully self-funded, with the exception of stop loss or a captive on the back. Period.
Stop loss is in case the medical bills of the employees exceed the amount paid in that year.
Correct.
You've got a stop loss policy. What was the other one that you mentioned?
A captive. So there's 2 ways to manage stop loss, basically.
Okay.
And that's either with a direct policy with a carrier like Tokyo. You can go and you can say, hey, I want to handle the first 100,000 or 200,000 or 300,000 of any particular incident. So that's your specific incident. Okay, so spec for short, and then ag or aggregate. I don't want to handle more than $1 million in large claims or claims in general. That's a direct policy. that you can go by. Each carrier kind of has its own appetite and its own preference, but the advantage of this piece is that your employees don't see a change on the front if you have to change stop loss on the back if you have a bad claims year.
Yeah.
Okay.
And the stop loss policy can decrease over time.
It can decrease or it can increase.
Yeah, depending on how you do.
You can, I'm recommending 2 increases this year. I'm recommending 1 decrease this year.
Okay.
So it'll just depend. But, the longer you go without big claims, the lower your premiums typically get on that. So your plan runs well. You got a healthy group. You've got a surplus. You can do whatever you want with that surplus legally.
The self-funded concept is super interesting. I think fully funding means, let's just break this down. So I'll break down my understanding and then you can just correct it. A fully funded plan is generally, I'm going to throw out some prices. Are you ready for this?
Yeah.
So anywhere from $1,200 to like $2,700 per month per employee family. Increasing by 8 to 12% a year, as I just learned.
That's a fully insured plan with a healthy group.
Yeah. And that plan gives them like a $3,000 per person, like a $10,000 per family out of pocket deductible thing.
Yep.
But that's low. That's low. Oh my gosh. So those are the rough numbers I always throw out to people.
Right.
It's right around this way. So fully funded means that the employer and employees, right? They take out so much per paycheck from the employees and the employers, and they pay this policy, and 100% of that money is gone to the void of coverage.
That's correct.
A level funded plan, I don't understand as well. Will you just break that one down?
Yeah. So it's in between self-funding and fully insured. You self-fund claims up to a ceiling. So $15,000, $20,000, $30,000, $100,000.
I see.
Whatever you're comfortable with. And then the insurance company kicks in after that. The advantage of this plan is if you come in under, then you are subject to a refund on your premiums that year. So you can put dollars back into the plan and often back into the actual bank account of your company.
Oh, that's cool.
So you can get money back. There are plans out there that offer a 100% refund on all unused premium dollars.
Oh, that's incredible.
Yeah. There's not too many, but there's some really good ones we're seeing right now. And I think we're trending that direction.
That's cool. Level funded seems like the way insurance should operate.
Should.
Just in general.
Well, and to a degree, like we've forgotten the purpose of insurance around medical insurance, right? With every other type of insurance, there's a cap on what's going to be spent. Not medical. On medical, you spend up to here, and then the insurance company covers everything beyond that.
Right.
It's an unlimited coffer. Right. No wonder there are so many medical scams out there, because they know if they can get their hand in that bottomless cookie jar, they can fund their garbage ideas for life. And frankly, this is why so much bad or subpar care exists.
Yeah.
Because they all they have to do is legally operate under a doctor's license. And maybe sometimes they aren't even doing that. They're still able to go put their hands in the claims jar.
Florida had some big time exposures to that space. I remember when I was there.
Don't get me started on Florida.
There's some massive corruption over there. It's wild.
Yeah, there is. And to that end, like Florida's insurance environment operates completely outside of NAIC standards because they've had to crack down so hard on all of that. Getting licensed and staying licensed in Florida is not easy. And with good reason, right? And maybe we'll see some changes in the coming months and years around that. I know that the DeSantis administration and others have talked about making some changes there, but this is probably the one time that I'm okay with a state not lining up with the other states and doing things differently. Yeah.
But to your point, I think the prices that are paid out for various parts of that person's healthcare equation are often exorbitant because they're just billed out at 300% of what Medicare pays.
Right.
So they're just billed at that with the hopes that they're going to collect a fraction of that.
Right.
And so unless you have somebody bird dogging that space and just holding the hospitals, surgical centers, those are the ones that are pretty exorbitant in their price, what they charge.
Right.
For instance, I had a knee scope, and the hospital was going to charge me a facility fee of like $20,000, $16,000 to $20,000. I I have a vested interest in like mitigating because I don't have a big plan. And so I'm like cash paying for this. And so I went up and I was like, hey, let's go to a surgical center for this.
Right.
Surgical center gave me a price. I'm like, can you do better? I'm paying you cash today. And so I literally had to just negotiate. And they're like, actually, yeah, we can do this.
Yep.
And so it was a fraction of what the hospital was charging.
Oh, it always is.
And then I went to the surgeon, and the surgeon was going to charge this much. And he's like, actually, Medicare pays this much. I'll charge you this much. And I'm like, let's do that.
Great.
Let me pay you that. I'll pay you cash right now. And then
sometimes when you want to tell them cash pay, they glitch out. They're like, we don't know what to do with this.
Yeah. The only one I got hosed on was anesthesia because I couldn't talk to anybody.
You're right.
Literally, those guys are in a cave. They don't even care
They
about
come
me.
in, they stick that needle in your arm, they knock you out, and you're done.
It was 15-minute procedure. It was like $1,200 for anesthesia.
Yep.
I'm like, what? Yeah. Like, what? And I was unable to really like mitigate that. Like I couldn't talk to anybody. But to have a team that does that work
right
in a self-funded plan, what is that work called for a self-funded plan? Is it like administering the plan?
Yeah, there's having a third-party administrator who knows what they're doing there. That's their job. There's another piece called advocacy. And there's two pieces to advocacy. One is steerage, where you have a pre-approval process. And pre-approval is very irritating on
people,
the ground level.
Oh, yeah.
With your employees and their families.
Yeah. They're like, what do you mean I got to get pre-approval for this?
Right.
Yeah.
But the reason why it's done is to help control
cost.
What's being charged.
Cost.
Right?
Yeah.
And so there's ways to find out the best provider with the best results, the lowest rehospitalizations, the fastest recovery time, and who charges the least and still gets the best results within that framework. There's data out there that's been aggregated across all the insurance companies. You can use that data to steer your people to the best care and say, you shouldn't probably go to this doctor just because your uncle went there. Find the best doc that's going to give you, and okay, maybe his bedside manner sucks. Let's get past that. Right. And I want a doctor to have good bedside manner. I think they should come in and sit down and be kind. Right. Yeah. Like I think I get the vibe your bedside manner is probably pretty freaking good.
It's terrible. I'm a jerk. I'm a neurosurgeon. I'm basically a jerk.
Right. But at the same time, like if the guy's good at his job, just communicate directly with him and have him fix you. And it's okay. You're only going to be interacting with him on a very limited basis anyway. He's not living with you in your home. Yeah. So he has staff, et cetera. Work with them. The pre-approval process can be a really big help if it's designed right and designed to function quickly.
The other, I mean, just thinking, I have patterns for my clients right now that are very affordable, very transparent, and good care, good docs, good surgeons. I've established these networks and these systems already, and just in the cash space. And so being able to have a direct primary care doc in the center of that plan, almost already directing to some of these outcome spaces to some. If you and I work together, that is the secret sauce, because I have trust.
Yes.
I have massive trust with my clients. They like love and trust, and I love and trust them. And it is special. And so if with your information, your data, we can drive a plan to some of those more cost-effective spaces with trust, I think that is where now we're working together. You and I are working together. The client and I are working together, and even the surgeons, like we've got this all kind of hammered out from a transparency, but also from a quality care standpoint.
Absolutely. Let me walk through how you can design a self-funded plan in a way that will control it. And then I will teach your people how to push back.
Let's go.
So this is, how much time do we have left?
I don't even care. Let's keep going.
Let's do it. Yeah. All right. When we're pushing back, we've got to do it from a place of strength. So teaching you how to design a plan that's strong. And I hope the brokers who are listening to this learn what they can do as well, because this is going to affect care in the best way possible. The first thing to remember is you want to stabilize as many costs as possible within the plan. Okay, there's two ways to do that. The first is bringing what's called reference-based pricing to the table. There is a set price for any given procedure, medicine, hospital admission, whatever. That's the price for this plan. Therefore, if we know we're going to have so many ER visits, so many hospitalizations, so many XYZ things that hit the plan, procedures, whatever, it's fairly predictable on what that cost is going to be.
Roughly $150 Medicare?
Roughly.
Yeah.
Yeah. And you could even do double Medicare. And it can be
still pencil.
Right. Right. And it can still work. And there's nothing wrong with that, because if your plan is self-funded, you do want it to run well. And obviously the lower the pricing, the better it's going to run. But as long as you're in that roughly 1.5 to 2 times, you're going to be fine.
Got it.
Then you need to use subscriptions. Okay. So direct primary care, direct specialist care.
Yeah, I stabilize so much cost for folks.
Right.
Just a tremendous amount.
And prescriptions.
Yep.
Okay. Right. So if you can bring a prescription subscription to the table, say that 3 times fast.
I can't. It's
Those plans often hold anywhere from 500 to 800 medications that are the most common ones prescribed at day to day at $0 extra per month. So I'm on one, it's $25 a month, and it mails straight to my home. I'm on 4 maintenance medications. My head's a little broken, and so I need to manage that depression with some Wellbutrin and a few other meds,
Sure.
right? And it shows up every 90 days in my mailbox. No extra cost, $24 a month, right? This saves me time from having to go to the pharmacy. This saves me time from having to fight when they short fill me.
Yeah.
Which was happening a whole lot right before I got on this plan. And I was getting letters from my insurance company saying, hey, you've got only 2 more fills left. You need to switch to a 90-day supply. And then for the big piece here is you need to make sure that you have controls on things like GLP-1s, right? Any semaglutide, tirzepatide, any of these.
Any brand name
Right.
crap, because it's all like thousands of dollars.
Right.
Where, yeah.
And we know we're close to some biosimilar generic being released soon.
You're talking about the biologics like
Right.
Humira and those kinds of
Correct.
guys that have been
Correct.
around forever.
Right.
And they cost $30,000 a month.
And
like
they
it's
shouldn't.
Nuts. It's
They
nuts.
shouldn't,
Yeah.
but they do.
Yeah.
And there's some things we can do to control that. But there's also things like insulin that can be controlled on these subscription plans, where if you have that, it can come in at $19.95 an insulin vial. $19.95 for an insulin vial.
Yeah.
That's lower than Medicare.
Yeah.
It's
That's incredible.
remarkable.
That's incredible.
These kind of things can
Best
save
I can do in the
lives.
cash space is $45.
I believe it.
That's the best I can do.
Yeah. Yeah.
Yeah.
So if we can bring things like this to a plan and stabilize it, that's great. You want to have control mechanisms for health problems. So your person who is with your TPA that's in charge of claims, as well as your agent, should be regularly reviewing claims and then talking to you about who are those high claimants, what are the medications, what are the facilities that are charging too much, and figuring out a way to steer around that, or to maybe figure out how to make that claim land differently. So let's use Ozempic as an example. It's $1,000 a month if you go through insurance per prescription. Guys, that's crazy. It's a lot of money. What that does to a plan is not good. And I have data on data about what this can do. You have these meds that can actually be sourced from different places. And you want to be careful about how you're sourcing meds, because there's some countries, including Canada, that don't have an FDA equivalent. And as much as I've got issues on and off with the FDA, politically speaking, they still do set a standard. And you want to make sure that there's a standard there, and that the company that you're sourcing them through, if they are going out of country, keeps to those standards and tests them independently. But you can cut that to $250 per quarter instead of $1,000 a month.
We do that for our patients all the time.
Right.
Yep,
Right.
all the time.
This gets the people who are overweight, who have diabetes, the medications they need without destroying your plan.
Yeah.
Right.
Yeah. That's smart.
So we do that, and then figuring out how to narrow the network, right? Incentivize them to come to you,
Yep.
or to whoever their direct primary care specialist is. Incentivize them to go that direction, and maybe even give them a little bit of cash in a health reimbursement account, HRA, right? Say, if you go to the right doctor, we're going to give you 20% of the savings as a thank you from the plan. That makes a huge difference. We want to disincentivize out of network without barring it completely.
Yeah.
Because sometimes people need a choice.
Totally, people need a choice. And that's my biggest thing. Like, let's say, you bring Voyage Clinics as at the center point of a company plan. And those people have a relationship with their providers right now. They may have, they like them and they want to stay with them. And so allowing that, but then also incentivizing them to, hey, this is just another set of eyes or another. And by the way, at Voyage Clinics, you get 30 to 60 minute visits. They're relaxed. You can text or call when you need. So don't look at it as like a competitor to your current doc. Like, you can continue to go there, but instead of waiting 3 weeks to get into that person and getting a 5-minute visit, not even with that person anymore. Sorry, that's facetious, but that's literally what it is. Now you can just text. Yeah. Text Dr. John.
Yep.
And he'll just respond. Hey, oh, you got a UTI? I literally managed a UTI last night. Like, it's just so straightforward.
One of my friends locally, Dr. Dallin, he does this for his pediatric patients. He lets the parents text him. He will go to their home and he'll see their newborns there, so you don't have to take your newborn out and have them exposed. And I mean, we're talking about bringing another kid along. I'm going to make Dallin my pediatrician for the first little while there, because I want him to have the safety, or whoever my child, if it's a boy or a girl, have the safety of remaining in our home for those first several very vulnerable weeks that a child has. So, and then as they're,
I know Dr. Hubbard. He and I just had a dinner with a whole bunch of other direct primary care docs. We're talking about putting together a network so that way you can just have one source for us. And
that would be remarkable, right? Where we can write a single DPC network in each state.
Yep.
And
come see any of us.
There's some great ones over in Saratoga Springs. We've got Zenith, right? I have a friend who represents a direct primary care network similar to what you want to set up in Colorado. And he works with agents, brokers like me. And when he approaches a brokerage, if they're like, no, we don't like direct primary care, we don't see the value in it, he relentlessly attacks their book. And he will not let up until they say, okay, we'll work with you.
That's funny.
And I told him, I was like, man, you're like the mafia, Nathan.
That's funny.
But it's there is great value to bringing this subscription because it brings stability. And that's what we're looking to do, is stabilize these plans and get them to where they're behaving in a really good place. Speaking financially, you'll want to have at least 2.5 times expected claims in cash for the year. Okay. In case something goes sideways. Yeah. And something around stop loss doesn't work the way you want it to. And then to answer your question from earlier, there's 2 ways you can manage that stop loss. So we talked about the spec and ag, but there's also a captive where you can be pulled with other companies. You got to be relatively healthy or have a healthy group to be in these captives. If you have an unhealthy XYZ that happens, or that you're bringing to the group, a lot of times they're going to put what's called a laser on that. That laser will increase the price of a single person or single condition. And often there's a no new lasers clause in these contracts. I would never write a contract without a no new lasers clause, because I don't want my people to experience an unexpected cost there. So that's a super important piece to have. You can tweak this for level funded, where you can still have DPC, you can still incentivize. You have your statements of benefits and coverage that the insurance company will give you, but you as a company can write a plan document that will let you essentially write your own medical plan that's backed by the insurance company, where you can, again, send them to the direct primary care, send the direct specialist. We also need to incentivize order of care, whether it's fully insured, level funded, or completely self-funded. You go to telemedicine here. If you can text your doctor, do that. Then from that next step up, then go into his office, to your PCP's office. Then go to a specialist and or urgent care, depending on the situation. And then after that, let's talk about the ER. And then let's talk about, a hospital admission or can you go to a surgery center, right? But order of care needs to be incentivized correctly for your plan to run well.
And
also.
really, the direct primary care does that beautifully.
Right.
Beautifully.
So you have that relationship.
If it's a good, high quality direct primary care, just like there are high quality direct brokers and maybe like not less less high quality brokers, there's the same in the direct primary care space. There's folks that are still largely doing a product that is very much insurance based, 5-minute visits, scheduled 3 weeks out, like all the stuff. And they call themselves a DPC because they have a membership.
Right.
And it's just not the same product. It's not the same thing. We've had some clients come over to my clinic from some of those folks, and they're like, whoa, like we just spent 60 minutes with you? Like what? And I can text you? Like that's incredible. So I don't know, just like brokers, I think DPC, not all of them are created equal and
same.
Making sure that there's good folks. There's a whole way to vet them. And
question for you, when you're working with a patient, because you're not beholden to insurance, that can kind of expand what your prescription or type of care that you give to your patient looks like, right?
Oh yeah. So Medicare, for instance, they force Medicare folks to come twice if they're going to do 2 procedures. So for instance, like guy had a knee injection and then he needed some pre-cancer sprayed off with some cryo, and he wanted there was another, I think the other knee he wanted injected. And with Medicare, you could only do one of those at a time. You have to bring them back and bring them back and bring them back. But with my office, I just do all 3.
Great.
And then it's like super cheap and super easy. And
now he's feeling better.
And he's happy, and he doesn't have to go to the 3 times to go to wait for 45 minutes. And it's just lovely. Yeah, it's lovely. Yeah. Dallin, this was so fun. I learned a ton. Dallin. I'm sorry, not Dallin.
Let's have you erase that.
Dennis Walker. This is so fun. I learned a ton from you, and no, this is great. This is great. I think putting this out there not only for employers but also for brokers, and also for the community. I think it's brought so much openness to this space, and I really appreciate your candor. This has been really cool, man.
There's one more thing I can drive home.
Please.
CEOs need to own healthcare for their organization. My good friend Daryl Moon talks about this all the time. When the CEO owns the process, everything changes.
The CEO owns healthcare for their organization.
Correct. Mm-hmm. Correct. Not HR.
By owns, you mean takes responsibility for.
That's correct. It's his oversight. Mm-hmm. He sees what's going on there. Because the CEO typically understands numbers, but is also good with people and drives the vision, he can drive a vision of stronger, better, less expensive healthcare. HR doesn't want to change from what they're doing because that's a lot of work. The CFO doesn't want to change because, now he's going to have to refigure out his numbers. But the CEO is in charge of both of those. And he can say, no, we're making this change. We're going to take better care of our people. Get on board or get out. And to my CEO friends, hear me when I say this. Get rid of those people in your organization who don't want to make the changes necessary to keep your people healthy, to get them healthy, and to keep your plan under control, because what's going on right now is completely unsustainable. And unless you take control of that in your companies, nothing's going to change, and it's going to keep getting worse.
So how would they go about doing that? Because that's the trick without firing people and there's some unethical things.
Yeah, for sure. Remember that your brother-in-law is not always going to be the best broker. Mm-hmm. Okay. We call that the brother-in-law question. Right?
Find the right broker.
Right. Find the right broker and be willing to shop them. Remember, he's not going to be just going through a good renewal.
But he's my brother-in-law.
Right. Right. Give him the same set of vetting that you would give everybody else. Right. And be careful about who you hire. But as a CEO, you need to look at what's going to happen long-term with your company. Think about, where do I want my company to be 5 years from now? And then find a broker who can align with that vision, who brings you new ideas. Be willing to innovate, right? And so the ownership of the financial piece, right? Hold the CEO, or the CEO needs to hold the CFO accountable to that. And he needs to hold the broker accountable to that. But also the customer service piece. Your people are the end user, but you are the customer as the CEO. You're the client. You demand to be treated well on all fronts. Things change when that starts to happen. And when the CEO does own it, there's a local company here called Clegg Auto. Kevin Clegg has been described as a pain by more than one broker, but Kevin cares about his people. Mm-hmm. He wants them to be happy. And so he provides all of the resources. And typically when healthcare is better and is owned, you get better results, you get faster work, you get people flocking to work for your company. So you're not worried about whatever XYZ labor shortage is going on. You can typically pay them more competitively because now your plan's running better. Take the time to learn about it. And I know that there's CEOs out there, and I've met with them, I've talked to them. They say, I don't really understand healthcare. Take the time to learn it. Pick up a book, start learning how this stuff works. Listen to these types of podcasts, start learning, because if you don't, you're going to get taken to town by the insurance companies if you aren't already.
Super true. I love it. Those are great take-home points. Daryl Moon's book is pretty good. There's some DPC docs that have written some good books in this space as well.
Daryl shouted me out in that book. So
cool.
He and I are good friends, and we know what we're talking about when it comes to that level of ownership. But there's a couple other books, but I think the one that I like the most is going to be Dr. Tony Dale's book. He's the founder of Sedera, which is a health share. And I don't sell health shares in my agency, but theirs is probably the best one out there because they pay sharing requests and they manage their coffers very well. Great group of people there. And so shout out to my friends at Sedera and how they manage that, and especially to Dr. Dale and the movement that he's bringing within direct primary care.
Totally. Health shares they have a role in the coverage space. I think they're neat for kind of smaller situations, and we could nerd out for a while on health shares because they're pretty cool.
And, in case my compliance department's listening, no, I'm not selling them, and no, I'm not endorsing them, but I'm just noting that the guys at Sedera have sought to build a good health share business, and I feel like they do things ethically and right as much as they can there.
I don't have a lot of Sedera clients.
Really?
Like you would think they would tell folks about my clinic because I would save them a boatload of money, and their people.
Interesting.
But around here, I've got a lot of Zion Health Share. There's a few Christian Health Ministries.
Sure. And you got to be careful about those when you're an employer. You cannot incentivize somebody to be on a health share. The DOL made that super clear last year in a big letter. And there was actually, I was at a previous agency where that was part of our offering. And we sent out a letter to all of our clients, prospects, and partners that said, hey, do not incentivize, right? And the way to work with that is if you want to offer it, give a flat dollar amount for benefits, then let your people decide what they're going to do with it. That's the most compliant way. Again, not legal advice. I'm not an attorney, but as far as I can see and understand, like they can then use those dollars, but you cannot incentivize one way or another. You can incentivize them to follow certain physicians. You can incentivize them to go to a certain facility. You can incentivize them to be on an insurance plan. You can incentivize them to go see the doctor for preventative care. And engagement strategies like these have been shown to drive costs down.
Dennis, where do you work? How do people get a hold of you? We'll put this in the show notes as well.
Yeah. I'm with USI Insurance Services. We're the largest privately held brokerage in the United States. 15,000 plus clients. We're headquartered in Valhalla, New York. But one of the things that sets us apart as a company is we have strong local presence. So a lot of us have been with local brokerages before coming here. And we have some folks that have been with big national brokerages too. So the previous president from Hub International, which is probably our only other equal as far as competitors are concerned, he just joined up with us. He was the regional president. We're very glad to have him. But most of us brokers have been local before coming to USI and getting the insurance services there. 30-year-old company, privately held again, very stable, growing. I'm very proud to work for USI. They give me resources that none of my competitors have. Sorry, guys.
Can we put your number on the website too?
You can, yeah. Social handles are at Dennis J. Walker, except for LinkedIn. I'm on LinkedIn as Dennis J. Walker Jr. You'll find me there. I'm in a pink shirt. I like bright colors.
Let's go.
'Cause I'm from
Florida, baby. Let's go. Purple, pink.
Right. I'm in
Super.
purple today for those who are just listening. And I post a lot of content there around healthcare and what we can do. Instagram at Dennis J. Walker, X at Dennis J. Walker, Facebook and Threads are the same.
Thank you for joining us today, Dennis. This was so cool.
This was a fun one.
I appreciate you. Guys, to all our listeners, thank you for tuning in. Like and subscribe, do all the things, or don't. It's totally fine. Or just get off social media altogether. No big deal.
Make sure you follow USI too. You'll see some new different ideas as well.
USI. Thanks, guys.